Edith, you can actually. All right, I see us that we're live. Edith, may I go? Okay. Well, good afternoon. Welcome to the House and Government Operations Committee. Chairman Shane Pendergrass is the chair of the committee. I am the chair of the Public Health Minority Health Disparities Subcommittee. So we welcome you. Today we have 3 bills on the agenda. We have actually House Bill 44 and Senate Bill 295 will be the first bill. And we did send you a reprint, and thank you, Erin, for sending the committee the reprint and the information they need to make a decision this afternoon. We also have House Bill 517 and its counterpart is in rules, but we're going to discuss it, discuss 517 and then House Bill 935 as well. So we're going to start with House Bill 44, Senate Bill 295. And I am going to ask Erin to describe the bills, and then I will, if the sponsor of the bill is here, the sponsor can say a few words. Otherwise, I'll let the advocates speak, and then the committee can ask questions. So Erin, good afternoon.
Hello. The bill will modify the requirements for Medicaid reimbursement to an emergency service transporter for services provided in response to a 911 call. Reimbursement must be provided for medical services provided to a Medicaid recipient in response to a 911 call in situations when the recipient is not transported to a facility, and for mobile integrated health services. Reimbursement for mobile integrated health services must be specified in regulations and at least $100 per interaction. Beginning in fiscal 2023, MDH must increase the amount of reimbursement by $25 each fiscal year until the reimbursement rate is at least $300 for both transportation and medical services and mobile integrated health services. These reimbursement requirements will terminate on June 30th, 2025. In your reprint of the bill, there's an amendment that's been offered by the Senate sponsor that would strike commercial ambulance services from the definition of emergency service transporter. The bill also contains some study language. If you look on the bottom of page 3 on page 4, there's a requirement that MDH, in coordination with MIMS, study the adequacy of the rate of reimbursement that's authorized under the bill. And then also there's a requirement that MIMS study the emergency and non-emergency interfacility transport system for patients enrolled in Medicaid, including the process for responding to referral requests in a timely manner, the adequacy of reimbursement related to costs and performance standards. And this report would be due by December 31st, 2022, and provided to Senate Finance and HGO. And then House Bill 44 would be amended in the same posture as Senate Bill 295.
Okay. Are any of the sponsors here? Senator Galian, or I believe is Delegate Hornberger and Riley?
Yeah.
Delegate Riley, would you like to be heard?
Madam Chair, I don't see Senator Gallion or Delegate Hornberger, but I did invite one of the advocates that understands the amendments that were put on the Senate side, and also to conform it to the House bill from Mako, Dominic. I would like to have him speak now, if that's okay. And he can go through the amendments. Okay.
Absolutely, Delegate Riley. Dominic, good afternoon. Will you be so kind and address the committee?
Yes, so thank you, Madam Vice Chair. Dominic Butchko with the Maryland Association of Counties. Thank you very much for hearing this set of bills. These are hugely important to local governments and to EMS service. The COVID-19 pandemic just really showed us some of the shortfalls in our emergency response. And so this bill seeks to really shore up and give resources to those first responders. The last time that the reimbursement formula was updated was in 1999. Currently, it's set at $100, and EMS responders can only be reimbursed currently for transportation to the hospital. Now, EMS providers do so much more than that, and so this bill just seeks to amend that. So if an ambulance is called out, you're going to get reimbursed for the care that you provide. Sometimes it's more appropriate to give care in the field. Sometimes it's more appropriate to take someone to an urgent care other than an ER. So this bill just seeks to modernize the way we do EMS and the way we pay for it. Also, as originally drafted, it did include commercial providers working with the different Firefighter organizations, we did decide to take that section out. So that has also been amended out. And then we also are looking at mobile integrated health, which is healthcare in the field. Like I said, sometimes it's not appropriate to take someone to a hospital or urgent care. And so some of the studies are addressing what is the best way to reimburse for that moving forward.
Is there anyone else that would like to be heard from the advocate community besides Dominic?
Yes, hi, this is Pat Gaynor from MIMS. We're fully supportive of the bill and the amendment that has been offered. And thank you for taking this up.
Our pleasure. Now to the committee. Are there any questions or concerns regarding this bill 295? This is your opportunity to ask questions, to express your concerns.
Oh my God, yes.
Delegate Kaiser, you have some concerns?
No, I'm glad this bill is moving. Thank you, Madam Vice Chair.
It's okay. Seeing none, is there a motion on the bill?
There is a hand up, though.
Actually, thank you. Thank you, Madam Chair. Thank you, Delegate Kaiser. Madam Chair, I did have a question, but then I read the amendment and so I'm fine. So I'll take the opportunity to move the bill move the amendments.
I appreciate it, Delegate Lewis. It's been moved and second. Any questions or concerns regarding the amendments for House Bill 295? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none. On the bill as amended, it's been moved by Delegate Hill, second by Delegate Johnson. Are there any questions on this bill as amended? Seeing none, all those in favor say aye.
Aye.
Any opposition on this bill as amended? Seeing none, the bill passes and is unanimous. Thank you so much to everyone that worked on the bill and for the members for being here present today. We appreciate it. Next,
procedure-wise,
yes,
could you move House Bill 44 as amended to conform to Senate Bill 295 and vote on that as well?
Move House Bill 44 so it conforms to the Senate bill.
beautiful.
Second.
It moved in second. Any questions or concern regarding House Bill 44? And thank you, Aaron. Delegate Lewis, will you be so kind and lower your hand?
Oh, yes, ma'am.
Thank you.
Sorry.
Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? All right, the bill passes. Thank you. And it's unanimous. We're now on to House Bill 517. And the cross of that bill, Senate Bill 460 is in rules, but we are taking on 517, which is in the same posture as Senate Bill 460. So Aaron, will you just give us a quick description of it? I know it's a very long bill, and actually I'm going to ask Ms. Ellen Weber to then do a more extensive walkthrough of the bill. And then so that the committee knows, we are going to discuss this bill. We're not taking a vote on the bill. We're going to discuss it. I have invited the Senate sponsor as well, on Senate Augustine, who's here, and we will then have an open discussion and you can express whatever concerns you may have. Aaron, will you tell us what House Bill 517 does, please?
House Bill 517 with the amendments that are in the reprint that was sent to you would establish a consumer health access program for mental health and addiction care to assist state residents in accessing behavioral health services under public and private health insurance and address insurance-related barriers to behavioral health services. The program would be administered by an incubator entity, which would be the University of Maryland, Baltimore School of Social Work Center for Addiction Research, Education, and Services, and also by a hub entity. The bill establishes a consumer health access program for mental health and addiction care fund, and the governor is required to include $1 million in fiscal 2024 through 2026 to the fund.
Thank you, Aaron. Ms. Ellen Weber.
Thank you, Madam Chair. I appreciate the opportunity to share the amendments with the subcommittee. So I'll walk through each in terms of in the sections that have been amended. The first amendment was to add a provision to commercial law section 13-4A-01. And what this amendment will do is it will identify the Health Education and Advocacy Unit as the entity that is eligible for funding under the federal Affordable Care Act provision that funds states to deliver consumer assistance services. So this amendment was offered by the HEAU, and it was added to ensure that it's the HEAU that has access to those federal funds. If the Consumer Health Access Program were to be passed, it would not be able to apply for those federal dollars. The second amendment is—
Can I just, Ms. Weber, in the bill, it's page 2, lines 25 through 28 that she is speaking to.
Thank you, Erin, so that the committee may follow. Ellen, you may continue.
Thank
Thank you, Erin.
Thanks, Erin. So the next provisions are on page 2 of the bill. They are the definition section, section 13-4401. And that goes until page 5 of the bill. And the two, you'll see there's significant amendments to this, but they fall into several categories. The first is an amendment to the that adds a definition of consumer assistance services. This is an amendment that the MIA provided. And what it does is it uses this term throughout the bill to define the activities that the Consumer Health Access Program would perform. So it's a consistent set of activities, and you'll see throughout the rest of the bill that any other description has been removed, referring back just to the definition of consumer assistance services. There are also several technical amendments that were also offered by the Maryland Insurance Administration. Those were definitions of health benefit plan as well as provider. And those were, again, amendments that the MIA offered and were incorporated to ensure consistency and some ease of reference throughout the bill. The next amendment is section 13-4402, and that is on page 5 of the bill. And what this section does is, it removes the description of program activities, and again references this new definition of consumer assistance services. That is, again, an amendment that the MIA offered that was incorporated. It also retains the other purpose of the Consumer Health Access Program, which is to collect and analyze data to resolve barriers to mental health and substance use disorder treatment. So that is the amendment to 44-02. There were no amendments on 13-4403. But then going to section 13-4404, which is on page 7, the amendments are there. This relates to the implementation of the Consumer Health Access Program. And these, again, were amendments that the Maryland Insurance Administration offered in order to provide some additional structure. The first thing that it would do, and again, this is on page 7, it would establish a timeline for the launch of the program. And it is the incubator unit, the CARES program from the University of Maryland School of Social Work that would be the incubator entity. It sets the timeline for issuing an RFP for selection of the hub and a deadline for selecting that hub entity. It then would require the CARES program, the incubator, to select, or either directly or indirectly through the hub entity, the selection of spoke entities. It then retains all of the qualification requirements for both the hub entity and spoke entities that were in the original bill, but again, tightens up the language just a little bit based on the MIA's amendments in order to ensure that both the hub entity and the spoke entity have all these qualifications and conform and ensure that there are no conflicts of interest. And then the last thing that this provision does, again, this was a Maryland Insurance Administration amendment. It clarifies that the Consumer Health Access Program will comply with health privacy standards and security standards under HIPAA as applicable. So those were the amendments for 13-4404. The next amendments are to 13-4405. And those would be found on page 9. And in this 4405 speaks to the composition of the Consumer Health Access Program and its functions. There really weren't any substantive changes to this, but again, it was conforming the activities to the definition of consumer assistance services. This is the section that includes all of the annual reporting requirements to agencies, the General Assembly, the Attorney General, and the requirement to work with agencies and the General Assembly to address barriers to mental health and substance use disorder services. There were no amendments to 13-4406, which is on page 12. But going now to the bottom of page 12 and page 13, section 13-4407, this clarifies, this relates to access to health records. So the Consumer Health Access Program will assist consumers in resolving their own individual problems to gaining access to mental health and substance use services. In the course of doing that legal assistance, they may need health records. This section addresses and clarifies that the Consumer Health Access Program will develop a consent form, and it also prohibits the disclosure of any patient health information except in the form of aggregate data. So again, these were amendments that were offered by the Maryland Insurance Administration to tighten up that language. The next section that has an amendment is also on page 13. It's section 13-4408. This is a section that removes a provision that would have required employers that offer health benefit plans, substance use and mental health treatment programs, and other entities to actually post a notice about the Consumer Health Access Program. The Maryland Insurance Administration and several others expressed concern, including the League of Life and Health Insurers expressed concern that that amendment, that provision was too burdensome. It was modified to simply require the Consumer Health Access Program to develop a notice and to request dissemination of it. The next section that was amended is the appropriation section. It is section 13-4409 on page 14. What the original bill had done was to be a little bit explicit as to who would be the recipient of year 1, year 2, and year 3 funds, dividing that money between the incubator and then the hub and spoke entities. We realized that was too prescriptive, and we were seeking and received funding in the governor's supplemental budget contingent on passage of these bills of funding for year 2023. Because of that effort and that supplemental funding, these provisions are no longer necessary because the timeline would be completely upended by funding in 2023. Two other sections, 14-4410, which is the name of the program, that is also on page 14. That provision was requested by the Health Education and Advocacy Unit to ensure that the Consumer Health Access Program uses its full name to avoid any confusion with the activities of the Health Education and Advocacy Unit. So that amendment was added as well. And then finally, this was at the request of our incubator entity, the CARES program. The amendment on the end of page 4, on page 15, there is a consumer there's a Consumer Health Access Program Advisory Council that has been developed. And what this will do is it will include all of the relevant state agencies that have a role in insurance and outreach and education. They will have a seat at the table, as well as county health department, consumers, and other peers, other experts on equity, health equity issues, an expert on the Parity Act, in order for all of these 15-person council to provide guidance to the CARES program and to help improve it over the course of the 3-year pilot program. So those are the amendments. Thank you for that opportunity.
Thank you for your time and for explaining it to the committee. Now I would like to allow Delegate Robin Lewis to address the committee and then Senator Augustine. Then I'm going to open it up to the parties that have requested an interest in these bills. Delegate Lewis.
Thank you, Madam Chair.
My pleasure.
Thank you so much. Thank you to Senator Augustine, my cross-file for being present. Thank you to Ellen Weber for the walk through the amendments. So usually at this juncture, the House bill sponsor urges the subcommittee to support the bill on its merits. And I'll just remind all of you, hey, you've heard the bill already. I'll just take the opportunity to remind you that what we're trying to do here is improve the delivery of mental and behavioral health services to the people of Maryland who, whether they have health insurance coverage that offers mental behavioral health services or not, that they be able to afford themselves the benefits of care and treatment. We've got a long way to go in our state, despite all of our progress. This bill aims to create a stronger bridge between people and the services. This bill creates a sort of, we were calling it an ombuds program, but really it creates a connector process, like the navigator system we have with the Maryland Health Benefit Exchange that connects insurance seekers with insurance plans. This bill creates a program that will connect behavioral health service seekers who've faced obstacles getting the services they need. With that, the intricacies of the bill, the mechanics of the bill have changed a bit from its original posture. I think in a lot of ways, the mechanics of the bill are simpler. We've identified an organization that will serve as the administrative home of the program, and that's the University of Maryland School of Social Work. There's funding that's been provided through the governor's supplemental, which is something we did not have when the bill was introduced. So thanks to Senator Augustine for getting that. And I'll close simply by saying this bill gives us the opportunity to strengthen what we're already doing. And I hope that you'll give it your favorable consideration. Thank you.
My pleasure. Senator Augustine.
Thank you for the indulgence, Vice Chair, Chair of this, Pena Melnick, and also Chair Pendergrass, also for the indulgence. You all have just really such tremendous champions, and I'm really, really grateful. My cross-file of Delegate Lewis really laid a lot of it out, but I want to tell you all sort of what this is and what this is for me. And it's a story that I told, and it will be brief, I'm not a long talker, but it's a story that I told to Commissioner Bahrain, and before her, and so Mary Quay, who's on this right now, she's heard this story probably twice, because I also told it to Commissioner Redmer before that. And colleagues, it's a story where there was a suicide in my neighborhood, and it created a crisis in my family. And so we had to go to the hospital, and we got through that crisis. And then you get through that, you go beyond that, and we were following up on that. And so we went to our primary care person who gave us the referral for behavioral health services. And so I went to our carrier's website and stuff like that. And the closest place that provided services, and most of you know I live in Prince George's County. The closest was York, Pennsylvania. That was the closest service that was available to this. And I'm ashamed, I will tell you all, I just didn't pursue it any further. I'm desperately ashamed of myself for that I did not do that. And so we had some months where things were going okay, they were. And then we had another episode that drove me to this time to call our insurance. I did not get a live person. Once again, I was directed to go to the website to get to the network, get to our network. Again, no one close. So I called the primary again, and they said, oh yeah, no, that's the case. That's what it is. And they just, said, hey, just start calling people around us in where you are, offer to pay cash in order for you to be able to get, these these services. And so I started to call around locally to get I'm just trying to do what I can for my family member. And I can't, and I reach some folks, many of them, bad numbers that are on the website directory. And then I did reach a few, and they were like, oh yeah, well, we kind of are in this network, but we really don't have any appointments available. And again, it's just like, so shame on me. I didn't pursue it any further. And I'm just like really ashamed of myself for that. But that was my story. That is my story. That's what I told the commissioners. And he said, well, Malcolm, why didn't you call us? And I said, call who? Who was I supposed to call? What was I supposed to do? There's no denial. There was nothing like, what was I supposed to do? And folks, all the while, we're paying our insurance premiums. All the while, we are paying our insurance premiums. And so for me, that's what this bill is about. That's what this bill is about. I shared that with the Commissioner Bahrain, and I said to her, please work with us. Let's try to figure out a way to get this language right that will work, that works. And that's the product that you all see before you. And like I said, I'm just really grateful that you give me a chance to just to share with you where I come from on this bill, why I think it's important for the people of the state of Maryland. And I look forward to being able to listen to some of what people have to say. Thank you.
Thank you. Thank you both for your, for sharing with the committee. Now I want to open it up to the MIA, who I know and the carriers express some concerns. I know that Ellen just spoke on the importance of the bill, so did Delegate Robin Lewis. So I want to be balanced here. So why don't we start with who would like to start? The MIA? Yes. Go ahead and introduce yourself.
Madam Chair, this is Neil Karkanis on behalf of the League of Life and Health Insurers. Do you mind if I start first?
You may start.
Okay, thank you. Well, first off, I just want to say thank you to Senator Augustine for sharing his story. I've also experienced similar situations in my life personally, and I completely understand where he's coming from. So before I get into the nuts and bolts of our feedback on the bill, I just want to express my compassion and understanding to you before moving ahead. So that being said, I am Neil Karkanis here on behalf of the League of Life and Health Insurers. As you may remember, I testified before the broader Health and Government Operations Committee on the cross-filed version of this bill. I also did the same in the Senate Finance Committee. And as I said in both of those committee hearings, the League's position on the bill is favorable with amendments, and we have been willing to work with the sponsor to sort out our key concerns. Frankly, we were disappointed to learn that there were stakeholder communications that did not include all stakeholders. And unfortunately, we didn't see the amended bill until it was on a voting list in Senate Finance. But to be clear, we are certainly supportive of the concept of the state enhancing supports for consumers to find the care that they need. But this bill, even as amended, goes way beyond that scope, and significant substantive problems continue to exist as a result. Customer assistance is certainly great, and the need for connecting people to providers in this space is undeniable. But there's an investigative and legal representation piece in this bill that's problematic, as well as significant data sharing and trend analysis requirements that raise serious legal and public policy questions. Like I said, we requested the opportunity to work collaboratively to work on the bill in both hearings. Unfortunately, because we didn't have that meaningful opportunity, I'm here before you today to outline these specific concerns. We also know that the MI sent a letter, and we know that some of their suggestions were adopted, but to be clear, not all of those suggestions were adopted. We spoke with the MIA this morning about our specific concerns to verify and validate their legitimacy, and we appreciate that they are in this meeting today. This proposal duplicates the health education and advocacy unit's role in assisting consumers in filing complaints and the MIA's role in investigating those complaints and determining noncompliance with laws, all while requiring 3 layers of new bureaucracy. There's the incubator entity, a hub entity, and then the spoke entity or the specialty entity to serve as the program. Our favorable with amendment position envisioned a program that assisted consumers seeking services including those seeking in-network services under insurance plans. If there's a complaint to be filed, it needs to be filed with the MIA, and if assistance is needed, that's the purview of the HEAU. Why are we creating a non-governmental collection of entities to duplicate these functions? When we duplicate those functions of existing government agencies, the bill creates a myriad of regulatory concerns. There's both uncertainty about the anticipated relationship with the MIA and the overreach in demanding information held in confidence by the MIA. The bill creates a number of privacy and security concerns as well. Accessing information provided to the MIA in the due course of its business violates state statute and places the department in a precarious position vis-a-vis other regulators who treat the confidentiality provisions of state law as required in order to exchange information with other regulators. Carriers are concerned about the collection of information for the purpose of, quote, analyzing data, end quote, and, quote, identify trends and violations, end quote, when the program is not a regulator and will have limited access to information to draw conclusions that are not anecdotal. My colleagues that are going to follow me are certainly going to dive much greater into the detail relative to the legal issues here. But broadly, I must say that it's just not entirely clear what the entity that is being created even is. Like, what I mean by that is it's unclear whether this program is a newly formed state agency or some sort of quasi-agency. And that's important because understanding what the program is shapes how it can be legislated and frankly held accountable. As we know, the rules differ for public entities, quasi-public entities, and the like. So for example, is this entity subject to being sued? Is it subject to public ethics laws? Is it subject to the Public Meetings Act, procurement, audits, or anything else? Who's actually in charge of the program? Who runs it? Is it the dean of the university? So all of these questions, and I'm sure many more, are raised by first understanding what the entity actually is. But beyond that, it has a multi-layer design where private nonprofits are involved. I imagine that those external entities wouldn't be subject to the same bodies of law that state agencies are subject to. I'm just not sure. So apologies for the length of these comments. You all know I'm typically short and sweet before this committee and the subcommittee, but I needed to put all this out there. So with all that being said, we really appreciate the opportunity given to us today to outline these specific concerns, and we look forward to the discussion. Thank you.
Thank you for sharing with the committee. Who is next? Will you please be so kind and unmute yourself and introduce yourself to the committee?
Sure. Thank you so much, Madam Chair. This is Kathy Greason on behalf of Care First. I want to first echo the gratitude expressed by Mr. Karkanis for the opportunity to present our concerns today, and also to reiterate the compassion for the story that that Senator Augustine just shared. And he identified what I think is a gap that we were hoping this bill would address in a meaningful way. The gap being that there are resources available today to consumers to find avenues to care, but consumers don't know about them. Mr. Karkanis outlined the MIA as a resource, but as Senator Augustine said, who am I going to call? How does the normal consumer know that that resource is available? The HEAU is available. The carriers themselves, we all have robust programs for consumer referral. But when we saw this bill, we strongly shared support for the goal of improving literacy there and letting members know about these avenues to access care. So, as we continue this discussion, we just want to reiterate in the favorable with amendments posture, that's really, in our opinion, the value add. The challenge with the bill is it does so much more than that. In addition to creating this consumer assistance piece, which we strongly support, it also creates this sort of quasi-regulatory role for the program. And it also leaves ambiguity in what rules of the road apply in that case. And with your permission, Madam Chair, I'd like to walk through a few of those provisions, and please stop or interrupt me if it's too weedy. And I would also ask my colleagues at the MIA, please correct me if I misstate anything. As I said, we just seek to flag the legal issues that we see as legitimate and believe are consistent with many of the things that you have previously raised that are not addressed in the bill.
Go ahead.
So a couple of those points. To begin, it creates a regulatory role for this what we think is a non-regulatory entity. We still, as Mr. Karkanis said, don't know. To be specific, page 13 of the bill, lines 19 through 24, for folks that want to look, I'm going to read you just the clause that I'm talking about. It states that the program shall request and promptly receive the cooperation, assistance, information, and records from state agencies. That's the first problem. When they ask for these records from state agencies, there are not sufficient privacy protections in place, cybersecurity protections in place, or consumer data protections in place. So to talk about several of those pieces, there are several places in the bill where the program would be subject to certain provisions of HIPAA. For example, part of the bill says that the program and the hub and the spoke must have HIPAA compliant data security systems in place. But in Maryland, our cybersecurity law requires more than HIPAA. It requires what I would call HIPAA plus. In addition to having a HIPAA compliant data security program, carriers that hold this data and others that hold this data are subject to Attorney General reporting in the event of a breach. The MIA cybersecurity law, which Delegate Cullison's committee passed several days ago, also has additional requirements on folks that have this type of data, carriers. If there's a breach, we have to notify our regulator, we have to notify the member. These protections are not in the law for this entity that is asking to hold and use the very same data that we are subject to being protective with. That's the cybersecurity piece. Additionally, there's Public Information Act legislation that is very germane to this discussion. So today, when a member of the public requests information from the MIA on a consumer complaint, they have to do it in a certain way. And if they do it, the MIA is prohibited from sharing certain information by statute. So in that way, this bill begs questions of ambiguity at best or conflict of law at worst. Specifically, the MIA is prohibited by law in 2209 from sharing market conduct data that is procured in the course of an investigation on parity. It's not clear the breadth of data that this program wants to get, but that's patently prohibited. Secondarily, with respect to consumer complaints, they are bound by the rules of the road for Public Information Act requests. The exception to that is when counsel requests those records on behalf of a client. But from the breadth of this bill, this data would be used for much more than legal representation. It would be used for trend analysis. It would be used for policy making in the future. In the PIA context, if someone were to request this data from the MIA, the carrier would have an opportunity to weigh in, as would the member, and say whether or not they want that information to be shared publicly and for what purpose. This bill offers no path for such a discussion. The PIA allows for patent rejection of a PIA request for information that's proprietary and confidential. Many of the elements of mental health parity law and the way that carriers comply is proprietary and confidential. Our regulators can see it. Our regulators see a lot of it thanks to legislation passed by this committee that requires data submissions and periodic evaluation. But we are very uncomfortable with a third party, and we think that the state should be as well. We believe that our colleagues at the MIA would agree with our concern on that piece. So that's the confidentiality piece that's really at the heart of this concern. The second piece is that the purposes in the bill for this data to be shared are sort of twofold. The first enumerated purpose, again, I'm on page 13, lines 19 to 24, is for this new program to investigate the program member's complaint. The MIA is statutorily charged with investigating mental health parity violations. They are the only body that can make a determination in Maryland of whether or not a violation has occurred. So we're having a third party with no enforcement authority, no teeth. If they think there's a violation and the MIA disagrees, guess what? It's the MIA's jurisdiction under our law. The MIA does not have to abide by or agree with the recommendations made by this third party, who will be looking at a case in isolation, perhaps with selective data provided because of the rules that I just cited. So we think it's patently inappropriate for this program to do any investigating that's already the law with an appropriate regulator that has appropriate safeguards around privacy and cybersecurity to ensure that metadata and proprietary information is kept safe as it should be. So I've touched upon it. It's the regulatory role for a non-regulatory entity. It's an investigative role. And then the third prong of this legislation that really brings pause is that this information should be used to conduct trend analysis. And now let me give you a page reference. On page 11, lines 6 to 25, the bill talks about how data acquired from this small scope of program participants should be shared publicly to any entity that the program determines appropriate. Although it says that it should be scrubbed and aggregated, this limited data set, there's no opportunity for the consumer to opt out of sharing it. There's no opportunity for the payer to flag confidentiality, as I said before. So we're pushing this, not only are we collecting it in an insecure way, they're going to push it widely. And we also question whether it's a scientifically sound sample of data, right? Because you're talking about a specific consumer outreach program that hopefully for the parts that are valuable, touch a lot of people, but it's not going to touch everybody subject to mental health parity. And using this data set to draw conclusions about health equity, about gaps in mental health parity laws, when again, only the MIA can truly opine, at least as our state actor. So those are some of the legal issues I wanted to highlight. Again, I would invite the MIA to please correct me if I've misrepresented the law there, but really appreciate the opportunity to weigh in and happy to take questions. Thank you.
Thank you. I saw, before I go to Kimberly Robinson or Allison Taylor, is there someone here from the MIA?
Yeah, hi, this is Van Dorsey. There are a number of us here from the MIA. I'm happy to answer questions.
I need one of you to address the concerns that you have with the bill and the issues that have been brought up, please.
Sure. First, it's important for me to apologize on behalf of Commissioner Bahrain, who would be here if she could. She is, as we are speaking, actually, she is presenting at the NAIC conference in Kansas City right now to the Special Committee on Race and Insurance. So she apologizes for not being here. The MIA remains supportive of the concepts of this bill. There are a number of operational concerns that have been raised that the MIA does have. The main issue that the MIA has had remains to be, privacy concerns. Ms. Weber did mention that HIPAA language has been introduced into the bill. However, it's not quite the language that we added or suggested, rather. There's a phrase "as applicable" that has been added in two places in the bill. And what that does is, and this goes actually also to, what is the program? State agencies are not actually subject to HIPAA. And so by inserting the phrase "as applicable," it means essentially that phrase is going to be a nullity for the purposes of the bill, assuming that the program is a state, is some sort of agency or quasi agency. That also is a concern. We want to make sure that it's specified. Is it a quasi state agency? Is it subject to the Tort Claims Act? Is it subject to public ethics rules? I'm happy to answer specific questions with regard to the rules that we follow with regard to consumer complaints. I can go over that. Ms. Grayson was correct. We do an investigation initially on our own to determine whether or not there is a violation. At that point in time, a party, and I presume in this case it would be the program acting as counsel for the complainant, would be able to request a hearing, and then would be able to acquire documents relating to the particular investigation of that consumer complaint. That's what we understand the bill to allow the program to do. If it's meant to do more than that, then frankly, at best, there's an ambiguity on that issue.
Okay. Thank you so much, and give our regards to the commissioner. We appreciate it.
Well, thank you.
Our pleasure. Ms. Robinson, followed by Ms. Taylor.
Thank you so much, Madam Chair. Good afternoon to the members of the subcommittee. Kimberly Robinson on behalf of Cigna. And again, thank you for the opportunity to speak to you today about the lingering concerns for carriers with Senate Bill 460 and its House crossfile. I'm not going to repeat anything you've already heard from Mr. Karkanis or Ms. Grayson. I'm just going to flag just a couple of more points that jumped out, and these come specifically from the amendments that were added to the bill in the Senate, which we saw when they landed on the voting list in Senate Finance. The bill also adds in language shifting the scope of the entities that the program as the term is under the bill, is going to be interacting with, and specifically adds self-funded plans, Medicare, and I'm going to also flag that it also adds TRICARE. And I think in looking at the ambiguity about the role that this program is playing, it's the hats that it's wearing, whether it is truly that consumer assistance to connect an individual with care, which, as you've heard, is why the league came in favorable with amendments, because we understand that that is sometimes a gap for individuals. They don't know where to turn. We see the value in having someone who is able to help navigate that space for consumers. But as the language in the bill then spills over into the assistance with filing a complaint, as HEAU currently does, or investigating a complaint, since that language is in the bill, as the MIA does, or determining violations, and then calls for data to be provided by these other entities, that raises a huge question for us as well. As the members of Health and Government Operations are well aware, there's a limitation on how the state can interact with self-funded ERISA plans, and even how it interacts with Medicare plans and other federal programs. And so it's one thing when we're in the assistance space, as we know HEAU is able to do that because it is assisting the consumer, standing in the consumer's shoes. But when the bill starts to demand the provision of data and information under a state law from these programs, we have very serious concerns that, one, that's not going to be permitted, and that is creating a dynamic under the law that's not defensible, given the limitations of federal law where these programs are concerned. And so, again, we are supportive of the concept. We see what the overall vision is. This is more so where the rubber meets the road in terms of the words on the page and how this program is going to be executed and the open questions that still remain. So thank you for your time today.
Thank you. Ms. Taylor.
Hi, Madam Chair and Committee. My name is Allison Taylor here on behalf of Kaiser Permanente. I only have one point to add in addition to what my colleagues have said, and that is there was other legislation this session, House Bill 1082, that was looking to set up a consumer health literacy program. That bill passed the House, and one of the things that was added in the in committee with the amendments there was reference to health insurance to help support health insurance literacy. All the carriers supported that bill. We think it's great. We want putting that forward as a demonstrating our commitment to this issue, but also that we think that that provides a good model to get started on this important work of making sure all consumers know what their benefits are and can improve their health literacy.
Thank you. Ms. Sika.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott. I have multiple clients that are members of the Maryland Parity Coalition, including some that you're very familiar with, like NCADD and the Maryland Association for the Treatment of Opioid Dependence. We are strong supporters of the creation of this program. The General Assembly, I think, has worked for a number of years to create numerous policies that are aimed at trying to increase access to substance use and mental health services. There's certainly no doubt about your role in increasing funding for those services. You all have done a really fantastic job on this. And what we see the consumer health assistance program being is really being able to tie everything together, being able to make sure that people can actually access those services with the insurance that they have. And actually, I thought that Delegate Lewis's analogy to the navigation services that were created with the Health Benefit Exchange was pretty much right on point. It's not necessarily surprising that there's so much resistance from the carriers on this. I think that there is a fear that, if people actually had assistance, being able to utilize their insurance to the fullest extent, that, it might uncover where there are additional inadequacies. And so whether it's in networks or, in other ways. And so, I think that not wanting additional resources being allowed for consumers to try to access services is just a disappointment, to be perfectly honest. That we're not able to work together better to make all of that happen. I just saw the hands go up. I know everybody's. I don't mean to accuse anybody of anything. I'm just saying that I think as the nature of insurance is, it is just disappointing that we're not able to try to find some of these services that are able to actually just make sure people can utilize what they have so that we are filling in those gaps.
Okay, so this is where I am not going to acknowledge the hands that are up, and this is what I'm going to do. I try to be balanced, and I know I'm going to call on Ms. Cyphers last. Ellen already spoke, and I'm going to tell you what I'm going to do with the bill. Ms. Cypher, you're the last person.
Thank you, Madam Vice Chair. And I hate to be the person holding up the line of suspense, but and to hear what your plan for the bill is. Maura Cyphers with Compass Government Relations. I represent NAMI. They're the National Alliance on Mental Illness. I represent their Maryland chapter, which has 11 county affiliates. And I think just for some context and for the benefit of the subcommittee, because I am here on behalf of NAMI quite often, I started as a volunteer with NAMI back in 2008. So my history with them and my own personal involvement, aside from now currently having them as a client, goes way back. And I think what NAMI's executive director, Kate Farrenhold, would want me to say is that federal parity protections passed more than a decade ago, and Marylanders with mental illness still face tremendous barriers. And, I'm sure you're all kind of nodding your head because year after year, the Parity Coalition, on which NAMI serves, we have all collaboratively introduced bills, done task forces, work groups, studies. I have spent a lot of time in that tiny back room in the HGO office. And it's all to just try and require insurance providers to cover the care that we need and the care that we're paying for. And I gave you my context of NAMI. I'm a lobbyist. I spent a lot of time in HGO. I work on healthcare issues a lot. I worked for a former HGO member. So if anyone can figure out how to get mental health coverage, it should be me. But when I had postpartum depression, I was shelling out $800 a month for mental health treatment. And it's not because I had bad insurance. My spouse works in the insurance industry. So couldn't get in anywhere. I've never found a psychiatrist who takes insurance, and good luck finding one who takes Medicaid. So it's not, I think in the decade that insurers have had the time to get right with the people they're serving, they've failed. And, they say well, this only applies to small groups, or this only applies to large groups, or hey, Maura, that's your own anecdotal personal experience. But NAMI has 52,000 members, and I will bring them all into this committee because we have failed, frankly, on holding the insurance carriers accountable. And so I think let's hand the power back to the people. This program will empower our loved ones to know their rights, to navigate what is time consuming, and I think why Senator Augustine said he felt ashamed is because when you're having a hard time, these things are impossible to navigate. And then I think we could go down the line of prior authorizations and what people's rights are. And, I think this is desperately needed. We need this navigation. We need this advocacy unit. And I think it's our duty to help people understand their rights under the law. So I think Delegate Lewis, Madam Vice Chair, we have appreciated your unwavering support for the mental health community. And, I don't know if I'm missing something, but I know that the bill passed the Senate 2 weeks ago, and I'm glad that our friends in the insurance industry support what we're trying to do here, but haven't seen anything to improve, work on the bill. We do have a supplemental appropriation. It's conditional on passage of the bill, but we have been working this, and it's tough to be here at this late hour when it's critical to get this done. So thanks for hearing me out, and hopefully we can get to a place of passage.
Thank you. So I appreciate everyone giving us their thoughts. This will be a time where I will open it up to the committee, but I don't think that that is the right thing to do for the following reasons. You know, we do care, the committee cares about mental health, behavioral health. We passed a bill that requires parity. We have passed bills regarding network adequacy, work with many of you on that. We have passed bills regarding covering certain, care as well. This year alone, you will see that most of the expenses are health related. And I'm very proud of the work that we have done. Do we need to do more? Absolutely, which is why this late into session, we are dedicating this time, and the committee members are here and the chairman is here and most of the committee, subcommittee chairs are here because this is an important bill. But what we do know as well is that for a bill to have these many people that have concerns, it will be difficult to pass that bill. And that what we tried under, and I'm not going to speak for the chairman, but under her leadership, is to try to bring everyone to the table, which we all do, and try to bring and work on consensus. There are times where we don't reach consensus and we do it anyway, right? After we have given the respect and the opportunity for people to speak and try to work on it. But it seems as if there's still a lot of work to be done, respectful of Delegate Lewis and the senator, because I know they work very hard and are very disciplined with their work. But there seemed to be more work needed. So what I like to do is to ask the MIA and to ask all of you in the interim to come together with Delegate Lewis, which I know is willing, and Senator Augustine, to try to work and fix the bill, okay? In a way that it will give us in the community, in a balanced way, the help they need, while also respecting the privacy concerns and all these other concerns that many people have. It does not mean that we don't care. It means that we do care, but we want it done right in a balanced way. So what we're gonna ask you, and I want your commitment this summer, that you will work on it in the summer and the fall. I'm working on this bill. So Mr. Dorsey, do I have your word? And I know the commissioner will say yes, that you will work on this in the interim.
Absolutely. As I said at the outset, we very much support the concept of this bill. We've tried to work with, and we did work with Senator Augustine on this. And I apologize that there's still concerns, but it's we do think it's a great concept.
So I would like your office to lead it, please, with Delegate Lewis and Senator Augustine and with Ms. Ellen Weber. At the very least, those are the people I want in the room. In addition to Ms. Care First and the League, as well as Ms. Cyphers, Ms. Robinson, Ms. Seacock, okay? Everyone, I want them in the room, okay? And I would like you to please send the committee a letter stating that you're committed to doing this in the interim, and send it to the chairman and to the committee members. Delegate Lewis, if you need help in making sure, and I know the commissioner well, and she's going to do it, and Mr. Dorsey, they're honorable people of their word. If you need any help, will you please let us know?
Yes, Madam Chair. Thank you so much.
You're welcome. Ms. Weber, I know you're disappointed. I want you to know that the committee values your work because you have been instrumental with a lot of the NAMI and Ann Seacock and others in passing amazing legislation in this committee in the state of Maryland. So I like your involvement in this and making sure that we get it right, okay? And we respect and value your work. And to the committee members, thank you for allowing us to have this discussion. I wanted you to understand the bills and to see what the concerns were. And Delegate Lewis and Senator Augustine with the MIA's leadership and everyone else will work on it in the interim. And hopefully, God willing, next year, we will have a solid bill. I have everyone's commitment, correct? Thank you. So thank you for being with us today and for discussing this. And for our members, we have next House Bill 935. House Bill 935 is Health and Health Insurance Behavioral Health Services Expansion, Behavioral Health System Modernization Act. And for our members, just as a refresher, we were here this week, I think, the days, I don't even remember the days. And I had asked Delegate Heather Bagnall to go back because the fiscal note is like 7 million, but even more than that as the years go by, to look at and see what can we do now while we work on those other bills by reducing the fiscal note that can help with what she's trying to do. So I will actually, should I go to Erin? Will you describe the amendment or should I go to Heather Bagnall?
I can do it.
Thank you so much.
Of the bill in the packet. So all that remains of the bill would be, if you look on handwritten page 10, there is a requirement that on or before December 1st, 2022, MDH must obtain any federal authority necessary to implement a plan for the expansion of certified community behavioral health clinics in the state, including applying to CMS for an amendment to any of the state's Section 1115 waivers or the state plan. The department's implementation plan must ensure access to certified community behavioral health clinics in all counties of the state. MDH must review and consider options for adopting existing programs or services to provide wraparound services to children and youth with primary substance use disorders. I just now sent to all of your emails, there's more study language that fell off of the amendment, unfortunately, in the reprint, but it should be included. So if you check your emails, it was just sent. There is language that would require MIA in consultation with carriers, behavioral health providers, advocates, and other stakeholders to conduct a study on operational issues related to commercial carrier reimbursement of behavioral health, clinical, peer specialists, and crisis response services, and make recommendations for how to address those issues. On or before November 15th, 2022, MIA must report their findings to the General Assembly.
Thank you, Erin. Thank you so much. Delegate Bagnall, will you be so kind and tell us how this will help and present it to the committee, please?
Thank you, Madam Chair. So we went back to the stakeholders and we looked at policies that we could move now to build on the momentum, because as you said, we have record investment in public health this year. But these are, again, the programs that we know work. And this allows us to have the policy and work with the Department of Health to determine the best implementation for expanding those programs without us losing. Yes, sorry, I just got your text. Yes, that was the amendment that was dropped off of the reprint, the MIA administration language, because the MIA has already committed to working with our advocates, with the stakeholders, with the commercial carriers to figure out how they could reimburse for peer-to-peer services, because that was a piece that although they all want to participate, the way that they fee for service doesn't work it's again that square peg in a round hole. But all of these are policies that are budget neutral, but will move the needle on being able to understand the landscape of our behavioral health and expand the programs that are working and build on that momentum that we already have.
Thank you, Delegate. I'm going to call on Mr. Dorsey, since you're representing the MIA, just to make sure you are on board.
That the delegate has described it accurately. Yes, that is correct.
Thank you so much, sir. I appreciate it. We have next questions from the committee members. We're going to start with Ms. Kaiser, Delegate Kaiser, and then Delegate Martin.
Thank you, Madam Vice Chair.
My pleasure.
My questions are fairly simple. I just want to ask a question in terms of the reporting language. We're not asking the question of whether to do it, but how to do it. Is that correct?
That
Yes,
is
I'm seeing a
correct.
nodding head from
That is
Aaron.
correct.
And then my second, also very brief question is, does that study also include a cost estimate of some sort?
I'll let Aaron address that. I don't see it, but I'll let Aaron address it.
I mean, it doesn't say specifically, but I would think any plan to CMS would include cost estimates. If there's someone from MDH on the call, maybe they could clarify, but I would think.
Is there someone here from the Maryland Department of Health? Oh, yes, Heather, welcome, Ms. Shea.
Hi, thank
I'm
you.
so happy to see you. Go ahead.
Thank you so much. So yeah, a plan to CMS would include a cost estimate. That's correct.
Thank you for the question, Delegate Kaiser. Thank you, Ms. Check, for addressing it. Next, we have Mr. Martin, followed by Ms. Doyle.
Thank you, Madam Chair, members of the subcommittee. And I just want to really just wanted to thank Delegate Bagnall for all her hard work on this bill, and really pouring her heart into this effort. I want to thank the subcommittee for its consideration and support of this bill. It was a big bill and really omnibus measure that was introduced, designed to improve, all the different ways people of all ages across the state with public and private insurance, engage behavioral health services across Maryland, whether it's through primary care, specialty care, the crisis system. And obviously, there's some disappointment that not everything in the bill is moving forward, but, we understand that's the legislative process. The bill as amended will still get the ball rolling on some really important areas and lay a groundwork for future efforts. So I just want to, again, a big thank you to Delegate Bagnall and to all of you. And we're excited to continue working with you all moving forward to improve the behavioral health system.
Thank you, Mr. Martin, for the work you do. Next, we have Ms. Lori Doyle.
Thank you. I just want to echo my thanks as well to Delegate Bagnall and to you, Madam Vice Chair, particularly around the certified community behavioral health clinics. These have been game changers in other states. We expect the same will happen here. It's very congruent with our total cost of care model, and I think it will really help us meet some of the things we've been struggling with in the state in terms of the model and the expectations of the model. So I just want to thank you all very much for your support with that.
Thank you for your work and your advocacy in our committee. We appreciate it. I am going to open it up now for our members. Do you have any questions or concerns about the amendments that were presented? This is your opportunity to ask the question here and now. Are there any questions or concerns? Will you please be so kind and raise your hand? I don't see any. That being said, is there a motion? Actually, Heather, is your hand up? Okay.
Yes, sorry. Thank you, Vice Chair. I just have a question. So my reading of the bill says that MDH has to create this plan and submit it to CMS. But then what I thought I just heard was that there's a work group to look at not whether we implement this, but how we implement this. So I'm a little confused.
Aaron?
Heather, you don't have the MIA study language, so let me send that to you because I think that's what. Actually, check your emails because you should have been on that last one that has the MIA.
Okay, thank you.
Okay. So your question is addressed, Heather. Okay. All right. So on the bill here on the amendment, may I have
Move
a
the
motion,
amendments.
please? It's been moved. May I have a second, please? It's been moved in second. Are there any questions or concerns about the amendment? Seeing none. All those in favor say aye.
Aye.
Aye. Any opposition? On the bill as amended, may I have a motion, please?
Move the bill as amended.
May I have a second?
Second.
It's been moved in second. Are there any questions or concerns regarding this bill as amended? Seeing none, all those in favor say aye.
Aye.
Aye. Any opposition? Seeing none, the bill passes unanimous. This concludes our work for today. Thank you very much for your work, for your time. To the committee members, we couldn't do this work without you. We may have to meet one more time. We do have voting later today, so please pay attention to the bills, excuse me, the emails that are sent by the chairman and her staff. You have a great afternoon. Thank you for your courtesy.
Thank you. Aaron,
Our pleasure.
Aaron, can you send, I got nothing for today except the Zoom link and I just can't get the stuff. I know you just said you resent stuff. Can you send it to the laptop again, please? I just can't find anything. I get stuff from Lindsay. I just, for some reason, can't get it from you. Thank you.